Good afternoon, Bermuda, and welcome to the Bermuda Health Council's community discussions. Just a reminder for everyone, we will be providing you some good information today. And reminder that since we are in a pandemic, we would like you to continue to follow public health measures of social distancing, putting your mask on, and doing the things that are you're being guided by the government of Bermuda. But today we have an interesting discussion. Families, parents, and business owners are all still having questions as to what to expect and how to prepare in the months ahead as we have transitioned from managing COVID-19 or managing the complications of the virus here in Bermuda and dealing with the COVID vaccines, all the different measures that have been put in place. The Health Council does aim to provide the community some answers to some of the concerns and questions that they have in response to not only the COVID vaccine, but also the new variants and what we all can do to protect the public. So today we're excited to have Dr. Margherita Ghiselli. Dr. Ghiselli is the Regional Immunization Public Health Advisor for the Immunization Unit of the Pan-American Health Organization. We've heard about PAHO a lot in the past, and she's there in Washington, D.C., where she supports the country offices with the introduction of COVID-19 vaccines in the countries of the Americas, which Bermuda is a part of the Americas. She has worked for several years in countries of Central and West Africa, focusing on improving routine immunization coverage and emergency response operations. In February 2021, she joined the PAHO Immunization Unit to support routine immunizations and the rollout of the COVID-19 vaccines. Dr. Ghiselli has a strong and robust academic background and a work history, which we're excited to talk about how those things have shaped to where she is right now. She does have a Bachelor of Arts from the University of Pennsylvania and a Master's and Doctorate in Epidemiology from the University of Minnesota. She's also worked at the Centers of Disease Control and Prevention, focusing on improving routine immunization coverage and emergency response operations in Africa. So we are happy to have you, Dr. Ghiselli. Welcome to Bermuda virtually, and welcome to this conversation about a very important topic.
Thank you so much, and thank you for that introduction. Good morning, good afternoon, everyone. The topic of today's presentation is going to be COVID-19 vaccines, a topic that I think interests literally everyone in the world right now. I hope you can see the screen well. So we're going to be talking about the coverage of these vaccines, how many people have been vaccinated around the world and in the Americas, talking about vaccine effectiveness, how well do these vaccines work, safety, are they safe for us? And then we will provide a good portion of this talk to answering your questions. I have here some of the questions that are most frequently asked of us from countries all over the region of the Americas, but I'm sure you have your own as well, and we'll be happy to take those at the end of this talk. So first of all, the vaccine characteristics. So I'm sure you've heard a lot about the different vaccines that are currently in use, and names like Pfizer or AstraZeneca being used in everyday life and in the news, but there's actually a lot more than this. WHO, the World Health Organization, is currently evaluating 288 candidate vaccines. Of these, 104 are in clinical phase, meaning that we are doing clinical trials, and 184 are in preclinical phase, so still being developed. And this is of last Friday. Now, 6 vaccines have already been reviewed and approved by the WHO through a process called emergency use listing, and we'll discuss that process in a second. So these 6 vaccines are Pfizer, AstraZeneca, Janssen, Moderna, Sinopharm, and Sinovac. AstraZeneca has a number of entries on this slide because, well, the same vaccine is produced in different locations of the world. So India, Italy, China, Spain, South Korea, and I'm sure there's other sites that are being opened. To the right, you see the date in which each one of these vaccines received its EUL approval, meaning that WHO considers them to be safe and effective. And then further to the right, you can see SAGE, which is the Strategic Advisory Group of Experts on Immunization, which is an independent group of experts at the global level who reviewed all the documentation related to each one of these vaccines and published recommendations for the public, healthcare providers, anyone who wants to know more about how to use this vaccine and what it does. So the EUL, this is a procedure that WHO implemented to evaluate new vaccines, therapeutics, meaning drugs, and diagnostic, meaning tests, to accelerate their availability to people who are affected by emergencies. I think it's fair to say that today, everyone in the world is affected by the emergency that is the COVID-19 pandemic. So the EUL process is a very rigorous process to evaluate the safety, efficacy, meaning how well do they work, and the quality of these vaccines. Without this EUL approval, a vaccine cannot be part of the COVAX mechanism of distribution of vaccines. It just cannot happen. Each vaccine manufacturer has to produce a complete dossier of all the clinical trials, all the data, and all the findings for each one of the vaccines, has to produce this complete dossier to WHO. WHO will not consider any vaccine who does not have a complete dossier. Once the dossier is received, WHO calls an evaluation team made up of experts at the global level to evaluate all of these data and decide whether the vaccine meets the criteria to be safe and effective. And if those criteria are met, then WHO gives EUL approval. And as I said, without that EUL approval, a vaccine cannot be part of the COVAX mechanism to distribute vaccines. So we have been vaccinating in the world. The first person has been vaccinated only 7 months ago. So many of the data that we have on how well the vaccines work come from clinical trials, simply because there has not been enough time in many cases to accumulate enough evidence to evaluate how these vaccines work across all populations in all countries. However, there are many studies ongoing that determine how well vaccines work in the real world. And these are the data that we have right now. So you see that for each one of the 6 vaccines approved by WHO, these vaccines are very effective. The closer you get to 100%, the more effective it is, and the better a vaccine works. And these vaccines were developed to prevent severe disease and death. And you can see that for those, it works really well. We have some vaccines that hit 100%, others that hit 79, 85, 93%. And they work especially well in people who are particularly susceptible to these vaccines. So the elderly and people with comorbidities, with cancers, diabetes, respiratory illnesses, obesity, all of these. So the vaccines were really designed to work best for those who are most at risk and to prevent severe disease and death. Now, I know that in Bermuda, the country is using Pfizer and AstraZeneca vaccines. So I wanted to spend a little bit more time talking about the characteristics of each one of these vaccines. So first of all, Pfizer is an mRNA vaccine, a messenger RNA vaccine. That means that these vaccines teach our cells how to make a protein, or even just a piece of a protein, that triggers an immune response within our bodies. Now, the technology itself is not new. It's been studied for decades, but it is now being used in the COVID-19 vaccine, specifically for Pfizer and Moderna. So the context in which we apply this vaccine is new, but the vaccine itself, the technology, is not new. We've been studying it for decades. All persons age 12 or older are eligible to receive the Pfizer vaccine. And this vaccine is administered in 2 doses with a diluent, and you have to wait between 21 and 28 days, so 3 to 4 weeks between each dose. The injection is intramuscular, which means that you need to inject this vaccine in the shoulder. Either one, left or right, it does not matter, your preference. You cannot mix this vaccine with any other. WHO really recommends that you do not do so simply because we do not have enough data on the safety of mixing vaccines. So it's better not to do it. Pfizer, as I'm sure you've heard, requires very particular storage conditions, minus 80 degrees Celsius, which is an incredibly ultra cold chain storage. No household, very few hospitals have this kind of cold chain, have this kind of storage, this kind of freezer. So that's why using Pfizer vaccine can be sometimes complicated in many countries, simply because these refrigerators, these freezers need to be brought into the country first. But an unopened, thawed vial of Pfizer vaccine can last 1 month in a 2 to 8 degrees Celsius refrigerator, which is the refrigerator everyone has in their house. So the condition after thawing for 1 month are quite easy. It's just getting the vaccine to country that is complicated. For AstraZeneca, this is a viral vector vaccine, meaning that it uses a modified version of a different virus to deliver important instructions to our cells to develop immunity. Now, neither one of these vaccines can cause COVID-19 disease. It's impossible, it cannot do so. So both of these vaccines are perfectly safe when it comes to protecting you against COVID-19. For AstraZeneca, only people aged 18 or older can receive this vaccine. There are not enough data to show that this vaccine is safe among children yet. It is also administered in 2 doses, but the interval between doses is 8 to 12 weeks. The manufacturer of the vaccine, AstraZeneca, and multiple studies, independent studies afterwards, have shown that the more time you have in between doses, the better the immune response from the first dose is. And then the second dose is a booster. That's why we recommend 8 to 12 weeks. And there are studies now ongoing to see whether we can go beyond 12 weeks. It's also an intramuscular injection, either shoulder works fine. And very importantly, the vaccine is ready to use. It does not require any specific ultra cold chain, any refrigerator that we already use for routine immunizations like polio and measles will do, 2 to 8 degrees Celsius. You've seen at the beginning that AstraZeneca is produced in multiple locations, and it's the exact same vaccine. So whether you get 1 dose from, say, India and your second dose from Italy, it works fine because it's the same product just produced in different places. But again, WHO recommends not to mix these vaccines with others, like say Pfizer or Moderna or Janssen, simply because we don't know yet exactly what are the effects of this mixing. And one thing that I should have mentioned at the beginning, at the bottom of each slide, you will see some links. So if you want to obtain additional information, you can. All these links are public. Now, how is vaccination going in the world? These are data from 2 days ago, from a website, a very interesting website produced out of Oxford University in England that is called Our World in Data, and produces updated graphs of these kind every day on COVID-19 disease, how many people are infected, but also how many people are vaccinated. So in this graph, you see that the countries that are colored with the darkest color are the ones where most people have been vaccinated. So you see that these darker colors are found in the US and Canada, Chile and Uruguay in the South America, Western Europe, some parts of the Middle East, and then in China and Mongolia. So what about the other countries in the world? Well, as you can see here, their colors are very light, which means that very few people have been vaccinated. And this is a matter of just inequity. WHO has said very clearly that the vaccines right now are being distributed in a very unequal manner. And that is why, because many high-income countries like the US, like Chile, like Western Europe, have purchased directly from the manufacturer very early on in the pandemic. They have purchased these vaccines. And because these vaccines are new and do take a bit of time to produce, we are now in a situation where there are very few vaccines available in the world for low or middle income countries. So that creates a gap for vaccines. And so many countries have not been able to vaccinate the majority of their population as they would have wished. We will talk in a minute about what WHO is doing to fix this situation. But for now, this is what we have. In the Americas specifically, vaccination is ongoing in 49 of the 51 countries and territories in the Americas. The only two countries who are not vaccinating right now are Cuba and Haiti. To date, meaning as of last Friday, the Americas administered 587 million vaccine doses. And this means that 237 million people in the Americas have received their full schedule for vaccination, and they are considered to be completely immunized. If we look to the left, we see a graph of each country and territory and how they're doing in terms of vaccination. And we see that the countries and territories in the Caribbean are doing quite well. They're having a high vaccination coverage rate. And then you have the United States, which is also doing quite well, along with Chile. But then if you look around the 10% coverage, you start to see countries in Central America and in Latin America. And then you go down further down in countries that have about 5% coverage. You see many countries in South America. So once again, you see this big divide between high-income countries and low to middle income countries and how differently these vaccines are distributed. So let's talk about what WHO is doing for this situation. So from the very beginning, since March 2020, so really since the very beginning of the pandemic, WHO got together with other partners, UNICEF, Gavi, and CEPI, to create COVAX, which is a mechanism that bargains, that negotiates directly with the vaccine manufacturers on behalf of all participating countries in COVAX to obtain the best price possible for these vaccines. And the countries who participate in COVAX are literally 99% of the countries in the world. So I think there are 3 or 4 countries who are not participating, but everyone else is, whether as a donor, as a country who participates in COVAX, or a country who receives vaccines. So it's literally all the world got together, almost all countries in the world got together to create COVAX and negotiate with the pharmaceutical countries to obtain the best price. And the important thing of COVAX is that from the beginning, it said, we will deliver vaccine doses to all countries of the world, high, middle, and low income countries at the exact same time. And we will give the exact same number of vaccines to cover the exact same portion of the population in each country. So let's say that Mexico, for example, got enough vaccine doses from COVAX to cover 1% of their population. Barbados, Bermuda, Brazil, Peru, they all got enough vaccine doses to cover that same 1% of the population. Now, population size are very different between these countries, but the same proportion of population is being covered at the same time. So this is what COVAX is doing right now to ensure equitable distribution of vaccines around the world. I said in the previous slide that 587 million doses have been administered in the Americas. Of those, only 22 million come from COVAX. So a huge disparity. And that again is because many high-income countries purchased vaccines directly from the manufacturer as soon as the pandemic started, leaving other low and middle income countries with very little doses available from the manufacturer. Fortunately, in the last weeks, we've seen huge vaccine donations from the European Union, the United States, Japan, and other countries, Sweden and Norway. So the COVAX mechanism is receiving all of these donations, and they are including them in their next shipments of vaccines to different countries of the Americas, we know, and then to other parts of the world as well. And then in the last 3 months of 2021 and in 2022, vaccine production will have ramped up enough that there will be enough vaccine to go around really for all countries in the world. So right now, this summer, this is the difficult period where there are very few vaccines. And fortunately, we have received these donations that we are working into the COVAX mechanism. But starting from late this year and early next year, we will really see an increase in the number of vaccine doses available to everyone around the world. That's why we are spending so much time with each country in the Americas, in our case, to prepare the vaccine introduction processes, making sure that every country has a regulatory agency to review the vaccine data and decide that they are applicable, useful for their own countries, making sure that every country has enough storage, has all the refrigerators it needs to receive the vaccine, and then that every healthcare worker is trained to administer these vaccines. That's what we're doing right now. I'm sure many of you have heard about variants of concern. What are these variants? So to start, the SARS-CoV-2, which is the virus that causes COVID-19, because it's a virus, it mutates. That's simply what viruses do, they mutate. Somehow, SARS-CoV-2 has mutated into some variants that have either higher transmissibility or cause more serious disease. And these we call variants of concern. And there are 4 of them. Alpha, which originated in the United Kingdom, Beta, which originated in South Africa, Gamma, which originated in Brazil, and Delta, which originated in India. And these are the only 4 variants of concern that we know of today. Then there are variants of interest, which we don't know yet whether they cause increased transmissibility or disease. We just want to keep an eye on them. And then there are all the other variants of SARS-CoV-2, of the virus, that don't increase transmissibility, don't increase death, don't increase illness. They're just different mutations of this virus. So if you look to the map to the right, you will see a lot of red. And that usually causes a lot of concern until you notice that red represents other. All the other variants that are not of concern, not of interest. And then you see that they are the vast majority. What we have most in the Americas are the Alpha variant and the Gamma variant, which makes sense because Gamma originated in Brazil. So these are the variants that we are monitoring the more closely. But we are always looking for new variants. We're always monitoring. And if there are new variants of concern, we make sure to inform the public as soon as possible. So the big question is, how well do the vaccines work against these variants of concern? And the answer is pretty well. They work pretty well. Now, because these variants have, I think the first one, Alpha, we learned about it in December 2020. Once again, we've only had 7 months to study them. But there are a number of studies that show that, especially against the Alpha variant, all vaccines that we have, all 6 of them, work pretty well. For Beta, also we have good evidence. It's not as much as for Alpha, but we have good evidence, and for Gamma as well. Delta, which is the last variants that we've heard about, so the one for whom we had the least amount of time to study, we only know that how it works against 2 vaccines, AstraZeneca and Sinovac. But again, the results are pretty positive. So with the data that we have right now, with the variants that we know right now, we know that vaccines do protect against these variants of concern. So that is very encouraging news. And hopefully, as more and more vaccines come out of the pipeline and into the COVAX mechanism, there will be more and more way to protect ourselves against the variants of concern. Now let's move to frequently asked questions. As I said, this is a series of questions that I thought would be interesting, but it's definitely not the last word on any of your questions. So I'll be really happy to answer any additional questions that you may have. So the first question is, how long does immunity last? I got vaccinated, how long am I protected for? And the answer is, we really don't know, because remember, the first person in the world who got vaccinated with COVID-19 received the vaccine 7 months ago. So it's not even been a year. It feels a lot longer, but it's not even been a year. So we really don't know. We know that the people who have been vaccinated first are still showing signs of immunity, of protection against COVID-19. But how long that protection will last, We just don't know. It's just too early. What about if I had COVID? If I have been infected with COVID, am I protected? Do I even need to get the vaccine? Well, the answer is yes, you do need to get the vaccine because one, we don't know how long your immunity from the disease itself will last. Two, you are always exposed to the risk of reinfection. That's something else that we're studying. We don't know how often it happens, but we do know it happens. So how long your protection is going to last against reinfection, we don't know. And also, even if you are still protected by the immunity that the disease gave you, you want vaccines to boost up your immune system even more so that you are protected for longer. So really, there are no reasons why you should not receive the vaccine, even if you have been infected. The only time where you would postpone the vaccine is that if you are having symptomatic COVID infection right now. So if you have a fever or if you're coughing, but that's more to protect the vaccinator from exposure. But as soon as you are well, you can receive the vaccine. You don't need to wait. That said, in situations where there is limited stock of vaccine, which is happening right now in some countries, if you had a COVID-19 infection, if you have been ill, we recommend that you can wait, if you want, you can wait up to 6 months before receiving the vaccine, because your natural immunity will protect you against further reinfection. If you are in an area where there are variants of concern, we recommend that you may wait up until 3 months. But this is a suggestion. If you want to get the vaccine, and if you can get the vaccine immediately after your COVID-19 infection, you can. We're just saying that if you have had an infection, you can wait up until 6 months if you choose so. Booster doses, this is another question. Should I get vaccinated every year? Well, again, we don't know because it's not even been a year since the first people who have been vaccinated have received their dose. So we don't know. It might turn out that COVID-19 is like influenza, where you would need an injection every year, a new vaccine every year. It may mean that the vaccines that we have received so far will protect us for years to come. We just don't know. But there are many studies ongoing to examine exactly how long immunity lasts after the first series. And in that sense, also, we have no answers for a booster dose, a third vaccine dose. There simply are not enough data to show that you need a third booster dose at this time for any of the vaccines, any of the 6 vaccines. But this is still something that we are studying and examining very closely. If a third booster dose is needed, obviously we will communicate that to the public and to healthcare workers as soon as we know this. But right now, we don't have any evidence. And it's possible that it's just a matter of time. We just don't have enough time and not enough data points to make that decision right now. Should children be vaccinated? Excellent question. So we all know since the beginning that children seem to not have symptomatic COVID. Many of them, if they were infected, were asymptomatic, no signs, no symptoms. But all children, if they are infected, they can transmit the disease, even if they have no symptoms. So children contribute to the transmission of the virus, SARS-CoV-2. So for the longest time, well, pretty much up until 2 days ago, WHO recommended not vaccinating children to prioritize adults who are at much higher risk of disease and death. With data from Pfizer showing that the vaccine is safe and effective in children as young as 12, now WHO recommends that children 12 and above can be vaccinated. But then 2 days ago, and this is just to show you how quickly the information changes, 2 days ago, WHO recommends now that children and adolescents with severe chronic comorbidities, so diabetes, heart disease, lung disease, cancer, they are at risk of disease and should be prioritized for vaccination. So again, this is not WHO changing its mind. It's WHO and partners collecting enough data to make a recommendation with some information at its basis. So more information we have, the better our recommendation comes. So at this point, we are able to say with confidence that the vaccines are safe and effective for children, and that children with chronic diseases should be prioritized for vaccine because it reduces their risk of disease and death while not causing any harm to them. But in any case, if there is limited vaccine availabilities, adults should always be prioritized over children. Pregnant women, this is another hot topic. We've known since the beginning that pregnant women are more vulnerable to respiratory infections like COVID-19 and more likely than the general population to suffer from disease and death due to COVID-19. And in the Americas, there have been, that we know of, 200,000 pregnant women who have contracted COVID-19, and at least 1,000 have died from complications. Therefore, 2 days ago, WHO said that pregnant women should be included in the priority groups for vaccination. Why did WHO not say this before? Because we did not have enough data to show that the vaccines were safe and effective for pregnant women and their babies. Now that we have more information, we feel comfortable making this recommendation that pregnant women should be prioritized for vaccination. WHO and partners do not move forward until they know that the vaccine is safe and effective for a specific group. Another topic that has caused a lot of questions, thrombosis with thrombocytopenia syndrome, or TTS, blood clot. I'm sure you've heard in the news that there is blood clots associated with AstraZeneca and Janssen's vaccines. So let's see exactly what we're talking about. TTS means that a person develops blood clots while at the same time having a very low platelet count in the blood, which is very rare because you usually have or a low platelet blood count or blood clots. It's very rare to see both. And TTS is exactly both. So I'm sure you've heard that many countries in Europe and in the United States paused the use of these two vaccines so that their regulatory agencies could collect all the data available, review it, and determine whether or not to continue vaccinating. And after all of these reviews, every single country started using these vaccines again because they came to two conclusions. One, that there is a plausible causal association, which is a very technical term to mean it's possible that these vaccines may cause TTS, but if they do, the events are incredibly rare. So for example, for AstraZeneca, we're talking about 4 to 6 people per 1 million vaccinated with AstraZeneca. And for Janssen, that's about 28 persons among all the 8 million who have been vaccinated. So the chances of someone developing TTS after being vaccinated with AstraZeneca or Janssen is incredibly low. Actually, there's a much higher chance to develop TTS when you're not vaccinated. So the conclusion was for all the regulatory agencies, WHO, CDC, PAHO, all of them, that the benefits of vaccinating against COVID-19 is far higher than the risk of contracting COVID-19, because you are much more likely to get COVID and have a serious illness, serious signs and symptoms, be put on a ventilator or died than you are of dying of TTS. There is almost no comparison. You are much better off being protected by COVID-19, against COVID-19. And now that we know what TTS is, there have been a number of clinical guidances that have been developed for healthcare workers to help them decide how to treat these patients and who to monitor after vaccination, who is most likely to develop TTS. So in a month, we have learned an incredible amount about TTS, and we are now able to treat it as soon as we know what it is. So that's why all the agencies are recommending vaccination and will deal with any very rare event of TTS later. And then finally, your family is vaccinated. Can we return to normal? Well, you are vaccinated, and that means that your chances of getting seriously ill or dying of COVID-19 are now very, very small. And even if you catch COVID-19, you will either be having no symptoms or very mild symptoms. So why Should we return to normal? Should we throw away the masks? Well, we are still learning a lot. That is kind of the theme of this presentation. We're still learning a lot. We don't know how long the immunity that the vaccine gives you lasts. We don't know how well it protects others from receiving the virus from you if you have been vaccinated but then exposed. And there are always variants of concern that may come out, and we don't know yet how the vaccine will work against these still yet unexplored variants of concern. So all of this means that even if you are vaccinated, it's still a very good idea to implement those mitigation measures, the ones that we've heard since the beginning of the pandemic. Social distancing, mask, cover your cough or sneeze, wash your hands frequently, especially if you are in a poorly ventilated, enclosed, or crowded space. Because we're still learning about, this not means that the vaccines don't work. It still means that we don't know how the situation with COVID will evolve in the future. So we want to continue to protect ourselves and our families and friends as we learn more about the disease and how vaccines react to each aspect of the disease. So that's why we're still recommending that people protect themselves and others using social distancing and masks. It's the safest way to protect each other and ourselves. So, and to conclude, very quickly, what is WHO and PAHO doing right now? Well, WHO at the global level, meaning for all countries in the world, is still evaluating the COVID-19 vaccine candidates that are coming in, putting them through that EUL approval process, that very rigorous EUL approval process, and determining whether or not they are safe and effective. And it is also developing protocols and helping countries implement vaccine effectiveness studies, which is how countries determine whether or not the vaccines that they're using are safe and effective in their own population. So real world studies in their own population with their own conditions. And so far, all the vaccine effectiveness studies that have been conducted have shown great results for the vaccines. So the vaccines worked well in a lab, and they are working just as well in the real world. And that's really encouraging news. For us at the regional level, we are convening a meeting of a group of independent experts on immunization, technical advisory group, in the coming weeks to hear their opinion on many of the questions that we have answered up until now and see if they want to take us if they have additional recommendations for us. We continue to monitor the situation of the variants and see if there are new variants of concern, new variants of interest, and informing the public. We develop communication strategies for the general public and for healthcare workers to make sure that everyone has the latest information and that everyone knows what to do. And we have developed a number of new strategies, not only through Facebook, but also live tweet chats. You can always email PAHO, and I promise you we will send you an answer with any kind of question that you may have. We publish all the recommendation on each one of the vaccines on our website to make sure that you have the absolute latest information published online, full transparency. If you want to know about a candidate vaccine, we have a webpage specifically for that, that you can see how each vaccine is progressing. We try to be as transparent as possible so that the public will know that we select vaccines exclusively based on their safety and how well they work. So any questions, and also in forums like this one here, where you get to ask questions. Any kind of question at any time, we are more than happy to answer and provide you our best available information to date. And then finally, we continue to help countries implement their own vaccine effectiveness studies. We've helped Chile, Brazil, Uruguay conduct their own studies to prove that the vaccines that they use work really well in these countries, not just in the lab, but in these countries specifically. So that concludes my presentation. I hope this was useful. And of course, any questions, I'd be more than happy to answer. Thank you.
Thank you, Dr. Ghiselli. Thank you so much for providing an up-to-date recap of what's going on in the world of SARS-CoV-2 vaccines. We do have some questions that we'd like to get to. But let's start off back and rewind a little bit in terms of, so we had a virus that has come into the Earth's population. And the mitigation or the strategy that was developed revolved around coming up with a vaccine to kind of halt the virus from spreading in its tracks, or to, well, maybe that's the question. The vaccine that was created, I know you mentioned it, but what was the purpose of the creation of the vaccine?
Thank you. No, excellent question. It's a really important one. So at the beginning of the pandemic, you remember that we were seeing incredible numbers of deaths, and the news was full of people being put on ventilators, and we did not know what this virus was or how it was transmitting. So at the very beginning, in March 2020, WHO and partners worked with the pharmaceutical countries and said, look, we need vaccines that prevent disease and death. Because obviously we want to prevent deaths, but we also want to not overburden the healthcare system in all the countries in the world, because there are people who don't have COVID but have all sorts of other diseases, and they're not getting the treatment that they need because the hospitals are full of COVID-19 patients. So they're not going, and there's not enough human resources, staff to treat them. So we need vaccines that prevent severe disease and death, that keep you out of the hospital and that prevent you from dying. And that's exactly what the manufacturers did. They developed vaccines that were designed to prevent disease and death. Now, these vaccines were not designed with the idea of stopping transmission, because remember, transmission can be completely asymptomatic. You don't even know you have the disease, and therefore you don't need to go to the hospital. Now, what we are seeing as we examine these vaccines in the real world, we're seeing that they do prevent some transmission, but the real focus has always been on preventing disease and death. And that's what the vaccines are doing extremely well. I'm sure you've all heard of Dr. Anthony Fauci. He said that he would have been thrilled, very happy with a vaccine that was 60% effectiveness. And we have vaccines that are 90% effective. So incredible results in just a year. And remember that the first vaccine, Pfizer, was approved by WHO exactly 1 year after the very first case of COVID-19 was notified, December 31st. So an incredible achievement. And as you've seen, we have 288 other vaccines in the pipeline.
So the vaccine, based on kind of evidence, has prevented death within the world.
Yes, and we are seeing more and more data from each country that shows that very clearly.
And we do feel as though if there was no vaccine, the death rates would have been a lot higher from this virus that causes a disease.
Exactly.
A lot higher. But we are still seeing within the world, we're still seeing transmission, and we're still seeing areas where vaccines aren't available. I know India was highlighted a lot, maybe a month or two ago, in terms of the amount of death that was happening.
Yeah.
You showed on one of your graphics that Africa, at least from the mapping, the rate of vaccinations are pretty low. But we haven't heard too much about kind of mortality or transmission, at least in the large media, around what's going on in Africa. Can you provide any kind of insights into what's going on there?
So a couple of things, and again, this is all evolving. So the information to date. First of all, Africa has a much younger population than many other countries in the world. And we've seen that the virus does not produce such severe symptoms and signs in younger people. So that's something to keep in mind. Sometimes in some African countries, half of the population is younger than 18. So that has an impact. Also, Africa may not have the same surveillance network that other countries have. So sometimes for example, if someone were exposed to a COVID-19 patient in the US, we would go test because we know that we're a contact. But if we have no way of knowing who was a patient of COVID-19, or we have no indication that we have a testing site close by, we may not be tested, and therefore we would never officially be classified as a case of COVID-19. So that too is something that is ongoing. And then finally, it very could be that we have not yet seen the big waves of COVID-19 in some of the larger countries of Africa in the cities. This is something that is of high concern. And actually, in the last few weeks, Africa is reporting increases number of cases. It's still yet to see whether this will be a small wave, a large wave, or something else. And then finally, what we have also seen is a huge variation in COVID-19 number of cases depending on the temperatures, whether it's winter or summer. In many of the African countries, temperatures, seasons divide themselves into rainy and dry. They don't really have, many countries don't have a winter proper, as we in the northern or southern hemispheres, extremes of the northern and southern hemispheres, we would classify. We have seen great variations in South Africa, which is maybe the only country in Africa that has a very clear summer and winter phase. And that has been the country where we've seen the most cases. But also keep in mind that South Africa is also the country with the best surveillance networks and populations who are older than the average African age. So there's a number of factors there that contribute. But again, the situation is always incredibly fluid. We are seeing an increase in the number of cases right now in Africa, and that has been of great concern. And also to say that it has always been of great concern, which is exactly why countries in Africa have been receiving vaccines at the same rate as all the other countries, despite having a lower disease burden, a lower number of cases, exactly to prevent big waves.
So you just want to dig a little deeper into that. So we talked about kind of cyclical or winter and summer kind of maybe not transmissibility, but the amount of infections that are seen during this time. We're now in the summer, and I believe last summer it seemed like because everyone went outside and it was warmer that the infection rates were lower.
Yeah.
But then during the winter, there was a lot of discussion about this is going to heighten, and we did see a lot of more infections during the colder season. Are we expecting around the world, are we expecting some of that to replicate itself again this year?
Very interesting question, because the answer is we don't know, because we've never had, at least in the Northern Hemisphere, a winter and vaccines being applied at the same time. What we are doing is examining very closely the situation in Chile, Argentina, Brazil, who are having their winter season right now, to see what's happening. And it seems that the number of cases does increase, although not to the same levels as last year. Also, these countries have launched huge vaccination campaigns against influenza. So, and that's another strategy to free up healthcare space. If we are protected against influenza, we're not going to the hospital because of influenza. And so that too has helped facilitate the treatment of COVID-19 vaccines and possibly saving some additional lives, simply because the system was not overburdened. So once again, it's something that for the Northern Hemisphere, we don't know. We are collecting data right now from the Southern Hemisphere, and the situation looks better than it was last year. But it will be interesting to see what high vaccination rates and a winter season do to the number of cases.
And for the young people who are, or the youth, whether it be, between 12 and 35 or whatever it may be in terms of ages, you talked about the vaccine being created specifically to prevent, complicated illness and death.
Yep.
For someone who's 25 at the peak of their athletic prowess, they're healthy, they eat all their fruits and vegetables and spinach. Why is it important for them, considering that and not to complicate the question, but considering that we don't have full information about transmissibility, even amongst those who are vaccinated, why is it important for a 25-year-old to protect themselves against mortality or disease when they're at low risk or seemingly lower risk?
Two reasons. One, even if they're perfectly healthy, they can still get COVID and transmit it to their grandmother, their friends who have some illness. So they can transmit the disease and cause severe disease and death in someone else. And no one wants to be responsible for that. But secondly, again, this is a brand new virus. We've never seen it before. First time we've seen it was November 2019. We don't know what the virus does to the human body. We don't know if it may trigger some condition. We don't have the full spectrum. We don't have a full picture of what the virus does to the body. So even someone who is fully healthy may develop severe complications, and we're not quite sure why, because we're still studying this virus. It's brand new. So that's why it's very important to take the vaccine as soon as it is available to you to protect yourself and others. And, you know, maybe this 25-year-old perfect health will be infected, be asymptomatic, and will never know that he or she had the disease. But others around him or her will know and will suffer the consequences.
You made a comment about there's been strategies in other countries, and just talking about policy, other strategies around things like making sure that we address influenza to try to free up rooms in the hospital or make sure that there's access to care when needed. What are some of the other concepts that other countries have done, right? So again, we talk about a big portion of this is how do we keep the hospitals and the health systems, you know, running in a way that they can take care of some of these other disorders. Some of these other disorders are based on other lifestyle choices and food and so forth. But a lot of the conversation, and I think the public would say, a lot of the conversation has been about vaccines and keeping mortality and complications down for COVID-19. But you raised an important point. If we can keep people out of the hospital for diabetes and hypertension and stroke, I mean, it accomplishes part of the same effect. What are some of the kind of strategies that other countries are using to accomplish those kind of other indirect?
Yeah, I'll speak mostly about vaccination because that's my area, but we can touch on others as well. Offering very diverse solution to offer, for example, routine immunizations, making sure that maybe the vaccines are COVID-19 vaccines are offered away from the clinic so that there is no risk of infection and people feel confident bringing their babies to receive their routine vaccines, or people feel confident about going for their checkups. Something else has been to bring vaccination for any kind of disease to the people who are most vulnerable. So for example, the long-term health facilities. There has been huge amounts of work to bring the vaccines to indigenous populations in remote areas, where, by the way, healthcare services are quite poor to begin with. And to make sure that the people who are most vulnerable receive the vaccine first. This is also something that WHO has done specifically to try and vaccinate first those who are in areas of high vulnerability. So the migrant populations, refugees, indigenous populations, making sure that these people are vaccinated first because they're in situations of vulnerabilities, so that they don't have COVID-19 on top of other difficult situations as well. And then outreach, communication, developing messages specifically for different groups, making sure that everyone understands why WHO and the ministries of health are choosing some options versus others, and trying to explain what we can do and cannot do. All of this is to make sure that people feel confident to receive the vaccine and choose to go to the hospital only when it is necessary. We are not telling people don't go to the hospital if you have diabetes, absolutely not. But what we're saying is do the best that you can to protect yourself and manage your condition at home. And then when you have to, go to the clinic as you usually would, but maintaining those same social distancing and masks and all of that, so that when you get to the hospital, you are protected, you are not adding to the work of the healthcare workers, and things are running a little bit more smoothly. So there's a number of things that other countries have done to encourage vaccination and maybe move those vaccination centers away from the clinics so that there is no concern about going to the clinic for anything else.
That's a very good point. You don't want to, in essence, cross-contamination in areas where you get a large concentration of people.
And also, measles is still a very big issue in the Americas. It seems almost quaint, but measles is the most transmissible disease in the world. And the last thing that we want is an outbreak of measles on top of of a pandemic. And measles affects children younger than 5. It is deadly. That's the last thing we want. So routine immunizations, I'll say that because it's my day job, are essential to avoid any other outbreak of any other disease, because that would just make the work of the healthcare workers and of everyone else extremely difficult.
And speaking about children, so a question came in, how safe are children who are under the age of, for example, 12, who can't get the vaccine? How safe are they? Yeah. Especially in cases where we talked about comorbidities or they may have certain conditions. How safe are they?
So there have not been any studies published. I'm sure there are studies ongoing, but no studies published on the vaccine safety and effectiveness in children younger than 12. So that's why they're not being recommended for vaccination right now. We just don't know how safe these vaccines are for them. However, children younger than 1 have been shown to have signs and symptoms, even severe signs and symptoms of COVID-19, which is why, while they're not vaccinated, they should, if they show any symptoms, they should remain at home and do the same quarantine period as any adult would do. For children who are a little bit older, but still not 12, and remember 12 is the age only for the Pfizer vaccine, every other vaccine is still for 18 and older. These children, even if they are infected with COVID, they will most likely not show signs and symptoms. So it will be very difficult to determine whether they have been infected unless, there is a classmate who has been infected and therefore you test all the other children. So for them, they can continue to go to school if the schools are open, continue to play with their classmates. Just the recommendations would be for parents to use the same guidelines you would use for any adult who shows signs and symptoms of COVID. Quarantine for 14 days, make sure that you are washing your hands, maintaining social distance, wearing a mask to the extent possible. And then if and when vaccines become available for children, to vaccinate as well.
And any consideration of not only just for the children, but for the adult population on long COVID, this idea that you contract the virus enters your body. It may not cause death, but it can cause damage that can last for a long time. We may not know how long right now because it's only been a year and a half of
exactly.
COVID. But we do understand that there may be ongoing effects. Can you talk about some of the long COVID that we've seen?
So what we've seen have been issues, especially with the lungs, but other body organs as well. And as you say, we just don't know how long this will last, if the signs will go away over time, will they stop completely, will they continue forever? This is among the elements we are studying very closely, especially in populations who are already affected by another comorbidity. Are these long COVID effects more severe in people with diabetes versus heart disease? These are all elements that we are studying. What we do know is that the vaccine has nothing to do with long-term COVID or any long-term side effects. There have been now more than 2 billion doses of vaccine administered around the world, and we have not heard of any long-term effects from the vaccine. Short-term effects in the sense of 1 or 2 days of soreness in the arm, headaches, some maybe a bit of nausea, that go away in 48 to 72 hours, yes. But in terms of long-term effects, no.
So we do read some of the adverse reaction reports, and I know based on your understanding of how the reports read, but when they're capturing data around these adverse reactions, is there a direct association with the vaccine and these adverse reactions? So, for example, there have been kind of in this report saying that a person has gotten cancer, or a person's had a heart attack. How do we kind of read these properly, these reports, and are they directly causing these kind of complications or diseases based on the actual taking of the vaccine?
No, excellent question. So one of the elements that have been in the works, once again, since March 2020, since the very beginning, was setting up either setting up or expanding surveillance networks for adverse events after the COVID-19 vaccine, exactly to capture all data relating to any kind of adverse events. And by adverse event, we mean any medical condition that occurs after a vaccine. We want to capture them all and then review the data and determine whether there is any causal association with the vaccine. And so far, the one of the blood clots is the only plausible that it could be. Still collecting data on it, but that is the only one. Heart disease, heart attack, stroke, even fainting. Fainting is also considered an adverse event following immunization. All of those have been analyzed and there has been no causal relation found with the vaccination. Fainting, but that's just because of the needle. And that can happen with any vaccine. But for all other elements, the US has a very strong network that has been collecting data on pretty much everyone who's been vaccinated. And TTS has been the only one to emerge in the whole conversation since December 2020, since we started vaccinating. On the other hand, it needs to be said that many countries in the Americas don't have as thorough a surveillance system for adverse events as other countries. They're still expanding it. They're implementing it right now. So it is possible that there may be some adverse events we just don't know about right now. So that has been in the works since the beginning of this pandemic. All countries have been fully trained on how to set up their surveillance systems for adverse events. All countries are implementing that system. They are starting to collect data. Their Ministry of Health have access to these data. And what PAHO is trying to do is also to analyze these data all combined so that we have a much larger, sample size and we can draw much better inferences from all these data. Once again, a work in progress, but it is at the very forefront of the work that PAHO and the Ministries of Health are doing, because once again, we know that vaccines are safe in the lab. We are evaluating right now how safe they are in the real world, and the results are pretty good so far, but there's still a lot of work to be done in this regard.
You mentioned the United States, and there's often kind of I don't know if it's a lack of clarity in terms of how the FDA versus CDC versus WHO, how they all operate together, or are they independently making decisions?
They are independently making decisions, but they are working off the available data. Now, CDC, because it is a domestic agency, obviously only reviews data from the United States. But oftentimes data from the United States are the more complete and the high quality ones. So they are certainly shared with WHO and PAHO. So the decision is arrived independently, but the data sets they review may be the same.
And determining who to follow is based on the discretion of each country, or should we all look to the WHO as kind of the global ambassador per se? What is your recommendation?
So CDC as a domestic agency has a mandate, an actual mandate to advise the states of the United States on what to do, but then the actual sovereignty remains with each state. And for WHO, it's the same thing. WHO has the mandate to issue the recommendations, but then each country has sovereignty to make the decision whether or not to take the recommendations of WHO, take only a part, take the recommendation, but implement it in a certain way. And that's where the country offices of WHO closely help the Ministry of Health to make sense of all the information and determine the best strategy for each country. But the final decision always rests with the country, just like with CDC, the final decision always rests with the state. So we, WHO, CDC, provides the best available evidence and the best scientific recommendation. The final decision is in the hands of the elected authorities.
Okay. And so when people say that the vaccines, and going back to, again, this regulatory framework that we're talking about, when people say that the vaccines are not approved or still being tested, can you clarify what this means? You talked about the emergency use kind of language. Can you just talk a little bit more about that?
So any vaccine has to go through very rigorous steps of testing, first in animals, then in a select group of humans, and then to wider and wider groups of humans under clinical trial conditions, so under very controlled conditions, before we can even start to talk about putting it in the arms of the general public. So that's what it means when a vaccine is being tested. It's going through all these steps, very rigorous steps, to determine whether it is useful, it does something, and whether it is safe. And safe to a certain extent. If it's just as good as getting the regular infection, it's not going to go through, because then we just get the regular infection. WHO has a very specific procedure, the emergency use listing, to review these data. But each country also has their own regulatory agency. In the case of the United States, it's the FDA. Each country, though, has their own body that also has to approve the vaccine if they want to use that vaccine in that country. So WHO is saying, we've done the review, these are the data, this is what we're saying. And then each country takes the data of the manufacturer and of the recommendations of WHO, evaluates them, and decide whether or not this specific vaccine is good enough for their own country. And all vaccines that are currently in use, I think there are 18 around the world, have gone through at least the national regulatory review. Again, WHO can only recommend these 6 vaccines because it has evaluated them with complete dossier and it meets WHO criteria. But any country can review can decide how much data they need to review and can decide whether or not to use this vaccine. So that's why you see some vaccines being used in certain countries, but have not been reviewed by WHO. It's not that WHO turned them down, it's that the manufacturer never presented the dossier to WHO, so WHO cannot make any recommendations because it has not seen the data.
When did the emergency use listing kind of methodology or structure come into place?
Oh, I'm not quite sure. I would say it probably started, like many things, with the N5N1 outbreak in 2003. I will need to check on that, but it has been in place for a number of years before this COVID-19 pandemic. It definitely was not created especially for this pandemic. It's been in place for a number of years, and the procedures are very clear and very well understood, and they move through the paces quite quickly.
And so it has been used before.
Yes, absolutely.
And I assume part of the emergency use listing has been brought on by global travel and the spread of disease, and
absolutely. So yes.
How do you manage them quickly?
Yes.
So we understand that the vaccine cannot cause COVID-19, correct?
Yeah. Correct.
And we talked about some of the adverse events and some of the reactions in terms of a fever or tiredness that at least we see, or sore arm. Is there anything else that the vaccine can cause that we know about?
That we know about? Not really. The vast majority of people, if they feel anything, will last 24 to 48 hours, 72 at the maximum. The only adverse event that we can plausibly associate with the vaccines, and only AstraZeneca and Janssen, by the way, is TTS.
Right.
That said, if anyone experiences some signs or symptoms for 10 days or more after the vaccine, that is the moment to go to your healthcare provider and say, I just got the vaccine, this is happening, what do you think? It may not be associated with the COVID-19 at all, but that is the moment when you should check in with a healthcare provider.
Another question from the public is, and you may or may not be able to answer this. There's a vaccine called COVAX, COVAXX. They're asking they brought up is a multi peptide protein based vaccine. Do you know anything about COVAX?
No, if it's COVAX, The vaccine, no, because that is one of the vaccines that has not been presented to WHO. And so we may read about it in the press, we may look for scientific articles, but we have not reviewed the dossier, so we have no recommendations to give. If we're talking about COVAX, the mechanism, then we can talk about it, but this is different.
Specific COVAX vaccine. Any insights, and this is again a controversial, probably a question, not to put you on the spot, any specific insights or positions of WHO on ivermectin?
On either what, sorry?
Ivermectin.
Oh, it's been, from the data that we have right now, is been shown to not improve the condition significantly in patients. So it's not a drug that we recommend simply because there is no evidence that it actually improves the patient's conditions. Now, there have been enormous amount of studies published on exactly the use of ivermectin. The issue is that there have always been small studies. The quality has not always been the best. So basically, we have not been able to pool enough data to make a final determination. With the data that we do have, it does not seem to make a significant improvement in the conditions of the patient.
And the prevention of transmission of the prevention of infection, any insights on that either?
Unfortunately, it's still the masking and the social distancing. That is still the very best way to avoid transmission.
And again, that is because the masking and social distancing prevents the aerosols per se from going from one person to the next.
Exactly. Exactly.
And there's just been a lot of, I guess there's been a lot of messaging recently of taking off masks, gathering in large events. You know, you see the NBA playoffs where the arena's full of people. And so some of that is maybe counter indicative of where we are right now. We're still in the middle of a pandemic.
Yeah, no, absolutely. But we need to also take in mind the context. So the United States, the CDC issued that recommendation. And like, once again, it's a recommendation. Each state, actually each supermarket can do what it wants, but each state can do what it wants. But it issues this recommendation because we had reached a sufficient number of people who had been vaccinated. So you taking off your mask does not impact me as a fully vaccinated person. You might infect me, but I've been fully vaccinated. So even if I develop the disease, I'm probably not going to feel anything. So that's fine. Specifically for these large events in arenas, New York City has even a higher vaccination rate. So that situation is even more specific. So I would say that these kinds of recommendations, which by the way, apply only to the United States, WHO is very firm that masking should continue, apply in specific contexts. And in many countries of the region, that context is, that vaccination coverage has still not been reached. I know that in some countries and territories of the Caribbean, we're quite close to that point, but then it's a decision of each Ministry of Health to whether or not to recommend lifting the mask mandate. The US has decided to do so, but each country is doing what it wishes. WHO is very firm that masking should be recommended. And indeed, I'm in my WHO office right now in Washington, DC. Because we're on WHO territory, we're still wearing masks when we're out in the corridor.
Understood. But we did say the Delta variant, and we're coming to a close, but we did say the Delta variant. We don't know as much about the Delta variant, but there is less protection from the vaccine to the Delta variant, or is that not the case?
We don't know because we've only been able to study the Delta variant now for what, 2 months? And we've been able to study it only in areas where it is present and the vaccination is ongoing. So because this is the real world, we can't really fit things so clearly as we would do in a clinical trial. We can't choose our vaccine, choose our variant, and then see how things work. It's the real world, so we have to take the vaccine that is being implemented and the variant that is circulating. And so far that we know of, with Sinovac and AstraZeneca, the Delta variant does not cause any additional burden of disease.
Okay.
Once again, as far as we know.
Right.
But there's no reason to believe that the other vaccines would not be effective against the Delta variant.
Well, Dr. Ghiselli, this has been actually a good conversation. I know a lot of the answers, not a lot of the answers, but there's a significant amount of information that we still are learning, right? This is a new virus that we haven't seen before. At the beginning of the pandemic, we saw a lot of death. We've put in measures to slow that death rate down. A lot of those measures have been successful, including mask wearing, social distancing, the introduction of vaccinations.
Mhm.
Have led to a slowing down of those death rates. But we still have a far way to go. We are still in the middle of a pandemic, and there's still things that we need to do as individuals and communities in terms of protecting ourselves and our population.
Mhm.
What we do know about vaccines is that they were developed and are successful at reducing or stopping, in many cases, a huge, highly effective proportion of those who contract are infected by COVID-19, and we've seen that to be the case. So for anyone out there who's considering taking the vaccine, know that there's protection there within that vaccine, not only for yourself, but for those that you love. And it's important for us to consider those things. For those who are dealing with other underlying conditions, remember, this is not the time to forego treating those conditions, making sure that you're getting the right level of exercise, that you're strengthening your body, that you're getting sunlight. You're going to see your primary care physician when you're feeling bad or something like that. Like, having another condition while being in a pandemic does not give us an excuse to forget that we do have these other conditions that are going on. So we want to do everything in a comprehensive way, including the normal things of eating healthy when it comes to making sure that our healthcare system is not overrun and we can take care of our populations as a cohort. So there's a lot of information here, right? And I think, again, a good takeaway is that we're continuing to learn about this. There are reputable information out there. The WHO, as you noted, and PAHO do keep their website up to date so that we can have the most recent information. So I do implore those within our listening and watching public to take good use of the information that's out there, to continue to ask your questions, understand that there are objective means of learning and continuing to follow the guidelines so that we can be protected as much as possible. We are still in the middle of a pandemic, so returning to normal is not for right now, but we can get there. But we have to continue to do our due diligence in terms of all the different measures that we can do. The Health Council is a resource for you. If you have any questions, we can possibly answer it ourselves, or we can reach out to the right people to answer them for you. But we are more than happy to continue these conversations. They are important. A month from now, the information may be brand new. So we want to keep these conversations and not let the information get old. So with that, I just want to thank you, Bermuda, for listening in. Thank you, Dr. Ghiselli, for sharing your expertise. I know there's a lot going on in the world right now, but your expertise and your support of the Americas region is truly appreciated, as are your colleagues, both at the WHO, PAHO, CDC, and all the people that you've come across. So with that, we want to thank you again, and good afternoon, Bermuda. Enjoy the sunny of this afternoon.